Salt or sodium chloride is necessary for maintaining physiological functions. However, most people consume more than they need, often exceeding recommended limits. Excess salt intake leads to elevation in blood pressure, which drives cardiovascular morbidity and mortality. Salt-sensitive hypertension is defined as an increase in blood pressure associated with increased salt intake. Every person has a set point blood pressure, and any deviation from this causes a proportional change in renal artery perfusion pressure, triggering a parallel change in sodium excretion that will ultimately alter blood volume and cardiac output, returning BP to the set point. High salt intake poses a physiological challenges. An increase in salt intake transiently expands plasma volume, increasing cardiac output. So, BP and renal perfusion pressure are increased, promoting sodium excretion, which in turn lower effective blood volume and blood pressure. During steady state conditions, there must be balance between intake and output of salt and water. Otherwise, there would be continued accumulation or loss of fluid leading to circulatory collapse. Central to this feedback loop is the physiological process of pressure natriuresis, in which increased arterial blood pressure is sensed by kidney as increased perfusion through the vasa recta, initiating paracrine signaling cascade leading to internalization of sodium transport proteins along the nephron. In other words, pressure natriuresis refers to the concept that increased renal perfusion pressure leads to decrease in tubular reabsorption of sodium and increased sodium excretion. The set point of blood pressure is the point at which pressure natriuresis and extracellular fluid volume are in equilibrium. In more detail, extracellular volume is determined by the balance between intake and excretion of salt and water by the kidney. Even temporary imbalance between intake and output can lead to changes in extracellular volume and potentially changes in blood pressure. Increased sodium intake induces a fine rise in plasma sodium, stimulating induction of thrust by the releasing of arginine vasopressin and subsequently fluid transfer from intracellular to the extracellular space and affect interstitial fluid volume. Extracellular sodium ion and fluid volume leads to hypernatremia, which occurs when there's too much sodium in blood, can lead to various symptoms and complications. Sodium plays a crucial role in regulating blood volume, blood pressure, pH balance, and nerve function. Here's what happens when sodium level become excessive. One of the main symptoms of hypernatremia is extreme thirst. Your body tries to compensate for the imbalance by signaling you to drink more water. Hypernatremia can cause lethargy, that is extreme fatigue and lack of energy. Sodium is essential for muscle and nerve function, so an imbalance affects overall vitality. Elevated sodium level may lead to confusion and cognitive difficulties. Sodium is critical for muscle function. In severe cases, hypernatremia can cause muscle twitching or spasm. When sodium levels are significantly elevated, it can result in seizure and even coma. Increased extracellular sodium ion and fluid volume can impact blood volume and increase it. When blood volume increases, it directly affects venous return and cardiac output. An increase in venous return raises the stroke volume, resulting in higher cardiac output. By the Frank-Starling mechanism, the heart's contractility increases as it stretches due to increased blood volume. When blood pressure increases above the renal set point because of increased total peripheral resistance or increased cardiac pumping, this also increases sodium and water excretion via pressure natriuresis. As long as fluid excretion exceeds fluid intake, extracellular fluid volume continue to decrease, reducing venous return and cardiac output until blood pressure returns to normal and fluid balance is re-established. Also, renin-angiotensin-aldosterone system, the sympathetic nervous system, renal transmembrane sodium transport, the kallikrein-kinin system, the nitric oxide system, eicosanoid, and the vascular endothelium are all involved in the pathogenesis of salt-sensitive hypertension. Renal mechanism of hypertension and salt sensitivity. In monogenic form of hypertension, obvious insult to the kidney alter renal hemodynamics or tubular reabsorption. For instance, constriction of the renal arteries, that is gallbladder hypertension, compression of the kidney, known as perinephritic hypertension, or the administration of sodium retaining hormones such as mineralocorticoid or angiotensin II, all are associated with the initial reductions in GFR or increases in renal tubular reabsorption before the development of hypertension. In monogenic human hypertension, the common pathway to hypertension appears to be increased renal sodium reabsorption caused by mutations that directly increase renal electrolyte transport or synthesis or activity of natriuretic hormones. As BP increases, the initial renal changes are often obscured by compensations that restore kidney function toward normal. Increased blood pressure that initiates a cascade of cardiovascular changes that may be more striking than the initial disturbance of kidney functions. However, one aspect of kidney function that is abnormal in all types of experimental and clinical hypertension is renal pressure natriuresis. The general type of renal abnormalities that can alter pressure natriuresis and cause chronic hypertension include preglomerular resistance, decreased glomerular capillary filtration coefficient, reduced number of functional nephrons, and increased tubular reabsorption. Some of these kidney abnormalities increase salt sensitivity of blood pressure, whereas other causes salt insensitive hypertension.